أعوذ بالله من الشيطان الرجيم. قل لمن ما في السماوات والأرض قل لله كتب على نفسه الرحمة ليجمعنكم إلى يوم القيامة لا ريب فيه الذين خسروا أنفسهم فهم لا يؤمنون وله ما سكن في الليل والنهار وهو السميع العليم. قل أغير الله أتخذ وليا فاطر السماوات والأرض وهو يطعم ولا يطعم قل إني أمرت أن أكون أول من أسلم ولا تكونن من المشركين. قل إني أخاف إن عصيت ربي عذاب قل إني أخاف إن عصيت ربي عذاب يوم عظيم. من يصرف عنه يومئذ فقد رحمه وذلك الفوز المبين. وإن يمسسك الله بضر فلا كاشف له إلا هو وإن يمسسك بخير فهو على كل شيء قدير وهو القاهر فوق عباده وهو الحكيم الخبير.
صدق الله العظيم. شكر الله لشيخ مصعب العبيد على قراءته الطيبة. بسم الله الرحمن الرحيم. الحمد لله الذي خلق الإنسان في أحسن تقويم، والصلاة والسلام على النبي الكريم نبينا محمد وعلى آله وصحبه أجمعين. أما بعد، صاحب السمو الأمير بدر بن محمد بن جلوي آل سعود محافظ الأحساء، الإخوة المشاركون والمشاركات، تحية طيبة، السلام عليكم ورحمة الله وبركاته. صباح مشرق ويوم مبارك وغايات منشودة بإذن الله في هذا المؤتمر الدولي الأول للكشف المبكر عن سرطان الثدي بين الحاضر والمستقبل في الأحساء. يا من يروم ظلال الخلد وارفة، نقل فؤادك في الأحساء واغتنمي، فبين أشجارها والنخل وشوشة تجلي عن النفس ما عانت من السقم. الأحساء بحضارتها وتاريخها العريق دوما تفتح ذراعيها لتحتضن مثل هذه المناسبات وتشرف باستضافتها. وها هي سعفات نخيلها الشامخة ترتفع ترحابا بكم، فأهلا وسهلا بكم جميعا وبورك خطوكم ومسعاكم. الحفل الكريم. الآن كلمة رئيس اللجنة المنظمة سعادة الدكتور عمر بن موسى بايمين، فليتفضل مشكورا.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه ومن والاه. صاحب السمو الأمير بدر بن محمد بن جلوي آل سعود محافظ الأحساء، أصحاب السعادة ومدراء الدوائر الحكومية، الحفل الكريم، السلام عليكم ورحمة الله وبركاته. يطيب لي أن ألتقي بكم في هذا الصباح لافتتاح المؤتمر الدولي الأول للكشف المبكر لسرطان الثدي بين الحاضر والمستقبل. إن التفكير في إقامة هذا المؤتمر نابع من احتياج المنطقة بل وجميع مناطق وطننا الغالي، فسرطان الثدي من أكثر السرطانات انتشاراً عند النساء، حيث بلغت عدد الحالات المسجلة في السجل السعودي للأورام لعام 2008 1152 حالة، بنسبة تجاوزت 25% من نسبة السرطانات عند النساء. ولو نظرنا إلى نتائج الإحصائيات من واقع السجل السعودي للأورام لعام 2009 لوجدنا أن عدد الحالات سرطان الثدي بلغت 1308 حالة، بنسبة زيادة 156 حالة، أي بنسبة 13%، وهو مؤشر عالي يفرض علينا تكثيف الجهود في مواجهة هذا الداء، خاصة إذا علمنا أن سرطان الثدي من أكثر السرطانات شفاءً لو تم اكتشافه مبكراً. ومن هذا المبدأ انطلقت دول عديدة على مستوى العالم في خطوات استباقية في مكافحة هذا المرض من خلال وضع برامج للكشف المبكر عن سرطان الثدي، مثل على سبيل المثال مثل دولة فنلندا التي بدأت في هذا البرنامج منذ عام 1987، ثم لحقت الدول الأخرى مثل بريطانيا وكندا وسويسرا وسنغافورة. لقد بدأ برنامج الكشف المبكر بالأحساء منذ 5 سنوات تقريباً، إلا أنه واجه بعض التحديات كما هو الحال في بعض مناطق المملكة، فمنها قلة البرامج التوعوية وثقافة المجتمع لسرطان الثدي وأسبابه وأعراضه، والقبول على عملية الكشف المبكر كانت ضئيلة. إلا أن هذه التحديات كانت هي من أكثر أسباب اكتشاف المرض في مراحله المتأخرة، والتي تقل فيه نسبة الشفاء إلى أقل من 20%. بفضل من الله سبحانه وتعالى ثم بدعم من وزارة الصحة متمثلة في مديرية الشؤون الصحية بالأحساء وبتكاتف القطاعات الأخرى، تم السعي في تجاوز هذه التحديات بوضع برامج عدة، فكان منها إقامة العديد من البرامج التوعوية والتي شملت المدارس والجامعات والمستشفيات والمراكز الصحية والمجمعات التجارية والجمعيات الخيرية، القيام بدورات سنوية لتأهيل وتطوير مهارات المثقفات الصحيات لسرطان الثدي، توفير أجهزة عديدة، وفتح عيادات متخصصة للكشف المبكر. والإيمان صحة الأحساء بأهمية الكشف المبكر وتحقيق رؤيتها في جعل مجتمع الأحساء خالي من الأمراض السرطانية، فقد أنشأت إدارة جديدة بمسمى إدارة الكشف المبكر للأورام، التي أخذت على عاتقها وبالتعاون مع جمعية مكافحة السرطان الخيرية بالأحساء على العمل جنباً إلى جنب في مكافحة هذا الداء. فكان هذا المؤتمر الذي نسعى من خلاله للاطلاع على آخر مستجدات الكشف المبكر لسرطان الثدي وتبادل الخبرات الدولية والإقليمية والمحلية. إن انعقاد هذا المؤتمر والذي يتميز بأنه أول مؤتمر دولي على المستوى المحلي بل والإقليمي الذي يتطرق بإسهاب في آخر مستجدات الكشف المبكر لسرطان الثدي وفي تبادل الخبرات العالمية، له خير دليل ومؤشر على زيادة الوعي والاهتمام بالكشف المبكر كوقاية من السرطان. ختاماً أتقدم بجزيل الشكر والتقدير لصاحب السمو الأمير بدر بن محمد بن جلوي آل سعود حفظه الله لتشريفه مؤتمرنا هذا، والسلام عليكم ورحمة الله تعالى وبركاته.
الكلمة الآن لرئيس اللجنة العلمية الدكتور عبد الرحمن بن صالح الملحم، أستاذ الجراحة المشارك وكيل كلية العلوم الطبية التطبيقية جامعة الملك فيصل.
بسم الله الرحمن الرحيم. صاحب السمو الأمير بدر بن محمد بن جلوي آل سعود محافظ الأحساء، أصحاب المعالي والفضيلة، أصحاب السعادة، أيها الحفل الكريم، السلام عليكم ورحمة الله وبركاته. بالإصالة عن نفسي ونيابة عن جميع إخواني أعضاء اللجنة العلمية للمؤتمر الدولي الأول للكشف المبكر عن سرطان الثدي، الحاضر والمستقبل، يشرفني الترحيب بكم أجمل ترحيب وتقديم الشكر والثناء الجزيل لدعمكم وحضوركم هذا المؤتمر. لا يخفى على أحد في وقتنا الحاضر معنى مرض السرطان ومدى انتشاره في العالم، وإنه أصبح أحد أهم أسباب الوفاة في وطننا الحبيب. وكذلك أصبح من المعروف أن سرطان الثدي هو واحد من أكثر السرطانات انتشارا لدى النساء، وأكثرهم شراسة وتدميرا للمرأة المصابة، وبالتالي تدميرا للأسرة التي يصاب فيها أي امرأة لما تعانيه المريضة وأسرتها من عناء وتعب وجهد جسدي ونفسي، وما يتبع ذلك من أضرار كبيرة للمجتمع ككل. ولأن الكشف المبكر عن السرطان البوابة الأولى لمحاولة تشخيص علاج المرض، وبالتالي تحسين نسبة الشفاء بإذن الله تعالى، ارتأت لجنة الكشف المبكر عن الأورام بمديرية الشؤون الصحية بالأحساء وبالتشاور مع أصحاب الخبرة والخير في هذا البلد مثل جمعية السرطان الخيرية بالأحساء، وتم الاتفاق على عقد هذا المؤتمر المبارك. إن هذا المؤتمر يعقد على مدار يومين، اليوم وغدا إن شاء الله، ويتكون من 6 جلسات علمية وبمشاركة من أكثر من 20 متحدث عالمي وخليجي وسعودي من دول الخليج كلها، ومن اليمن والأردن، وكذلك من دول أمريكا، سويسرا، عن سنغافورة. وقد رأت اللجنة العلمية للمؤتمر وبمساندة من المهتمين في هذا الموضوع في المنطقة أن تستفيد من خبرات العلماء من الدول التي سبقتنا في هذا المجال، وكذلك الدول التي تشاطرنا كثيرا في العادات والعلاقات مثل دول الخليج القريبة وكذلك دولنا العربية. ولقد عملت اللجنة العلمية مع باقي اللجان لهذا المؤتمر العمل الكثير، وبذلت أقصى ما عندها من جهد ووقت، وكان المردود الكبير هو موافقة أصحاب السعادة المتحدثين بالمشاركة في هذا المؤتمر رغم مشاقلهم العديدة العلمية والعملية. فلكل المتحدثين ورؤساء الجلسات الشكر والثناء الكبير. ونطمح كلجنة علمية أن يكون هذا المؤتمر فاتحة خير، وأن يستمر بشكل سنوي، وأن تكون هناك توصيات علمية قوية في هذا المؤتمر نحاول تطبيقها إن شاء الله، وكذلك متابعة مدى تنفيذها في المؤتمرات القادمة بإذن الله تعالى. في الختام أود أن أشكر الشكر الجزيل لزملائي أعضاء اللجنة العلمية والذين أعطونا من وقتهم الشيء الكثير، وكذلك الشكر للسادة أعضاء مجلس إدارة الجمعية الخيرية للسرطان بالأحساء الذين دعمونا بالفكر والجهد والمال الكثير. وأخيراً نشكر الأستاذ الأخي الدكتور عمر بيامين رئيس لجنة الكشف المبكر على تشريفي برئاسة اللجنة العلمية، وأسأل الله العلي العظيم أن يكون هذا العمل خالصاً لوجهه تعالى وخدمة لوطننا الغالي. والسلام عليكم ورحمة الله وبركاته.
الحفل الكريم، الكلمة الآن لسعادة رئيس مجلس إدارة جمعية مكافحة السرطان الخيرية بالأحساء الأستاذ محمد بن عبد العزيز العفالق.
بسم الله الرحمن الرحيم، والحمد لله رب العالمين، والصلاة والسلام على الطاهر الأمين عليه وعلى آله أفضل الصلاة وأتم التسليم. صاحب السمو الأمير بدر بن محمد بن جلوي محافظ الأحساء راعي المؤتمر، أصحاب الفضيلة والمعالي، أصحاب السعادة، ضيوفنا الكرام، السلام عليكم ورحمة الله وبركاته. من الأحساء باسمي وباسم إخواني أعضاء جمعية مكافحة السرطان بالأحساء، ونيابة عن المرضى ومستفيدي الجمعية، نقدم شكرنا لصاحب السمو الملكي الأمير سعود بن نايف أمير المنطقة الشرقية على رعايته الكريمة. نسأل الله أن يحقق هذا المؤتمر أهدافه ورسالته في توعية وتثقيف المجتمع بأهمية الكشف المبكر عن أمراض السرطان الثدي. فقد أثبتت الدراسات أن الاكتشاف المبكر للمرض يزيد من نسبة الشفاء إلى حوالي 97% بإذن الله. صاحب السمو، الأخوة الحضور، لقد أخذت جمعية مكافحة السرطان الخيرية في الأحساء نبل الهدف وعمق الرسالة لتحقيق رؤية مستدامة في نشر ثقافة الوقاية من أمراض السرطان في الأحساء، وذلك من خلال رعاية المرضى نفسياً وتقديم الخدمات الاستشارية للمجتمع المحلي وأسر المرضى مع المؤسسات المتخصصة محلياً وعالمياً. فقد نظمت الجمعية منذ تأسيسها قبل حوالي العام حزمة من البرامج والفعاليات التثقيفية والتعريفية والتوعوية. تم تنفيذ أكثر من 25 برنامج استفاد منه قرابة 8500 شخص، منهم المرأة والرجل والطفل. والجمعية تقوم بالعديد من الأعمال الخدمية لمرضى السرطان بالأحساء، منها تقديم الخدمات الاجتماعية المساندة للمرضى وذويهم لتخفيف الأعباء الاقتصادية المترتبة على المرضى كبرامج المساعدات المالية والإعاشية والإسكان ونقل المرضى والعمل على تحسينها بشكل مستمر، وذلك لصعوبة التنقل لعدم وجود مركز متخصص بالأحساء. وأيضا العمل على رفع معنويات المرضى وذويهم وإدماجهم مع المجتمع وتعريف المرضى وذويهم بحقوقهم المقررة لهم من الدولة حفظها الله، وكذلك تشجيع الأعمال التطوعية البناءة التي تخدم مرضى السرطان وذويهم في المجتمع المحلي. صاحب السمو، الضيوف الكرام، ونظراً لأهمية تحقيق التكاملية في المجتمع، فقد عقدت جمعية السرطان عدد من الشراكات مع جامعة الملك فيصل وجمعية البر الخيرية بالأحساء وجمعية المعاقين بالأحساء وجمعية السرطان السعودية بالمنطقة الشرقية والجمعية الخيرية لمكافحة السرطان بالرياض وغرفة الأحساء وأمانة الأحساء وهيئة الري والصرف. وتوجت هذه الشراكات بوزارة الصحة ممثلة في مديرية الشؤون الصحية في الأحساء من خلال هذا المؤتمر الدولي الأول للكشف عن سرطان الثدي بين الحاضر والمستقبل، والذي يعقد في الأحساء لأول مرة بمشاركة نخبة من المتحدثين والمتخصصين في مجال سرطان الثدي وأبحاثه من أكثر من 9 دول عربية وأجنبية، يلتقون هنا للتباحث والوقوف على آخر المستجدات الطبية والتقنية التي سوف تكون إن شاء الله والتي سوف تساعد بإذن الله في اكتشاف مسببات المرض على المستوى المحلي والعالمي وآخر ما توصل إليه الطب الحديث في مجال سرطان الثدي. وأخيراً نسأل الله العلي القدير أن يعم الفائدة ويرزقنا الخير والبركة في تحقيق أهدافنا. كل الشكر والتقدير لصاحب السمو الأمير بدر على رعاية هذا الحفل، والشكر موصول للجنة الفنية وعلى رأسهم أخي الدكتور عمر بايمين والدكتور عبد الرحمن الملحم والأخوة في الجمعية، وعلى رأسهم أخي الأستاذ عماد الجعفري، ولكل أعضاء مجلس الإدارة ولكل من ساهم معنا في إنجاح هذا المؤتمر. وأشكر الرعاة على الدعم الجميل، وهم أمانة الأحساء، غرفة الأحساء، هيئة الري والصرف، هيئة السياحة، مستشفى الموسى التخصصي، مجموعة الحسين والعفالق، السهلي للمواد الصحية. شكرا لكم ولدعمكم، ندعو الله أن يوفقنا وإياكم لما فيه الخير، والسلام عليكم ورحمة الله وبركاته.
الكلمة الآن لسعادة مدير الشؤون الصحية بالأحساء الدكتور عبد المحسن بن ناصر الملحم.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء وسيد المرسلين نبينا محمد وعلى آله وصحبه أفضل الصلاة وأتم التسليم. صاحب السمو الأمير بدر بن محمد بن جلوي آل سعود محافظ محافظة الأحساء حفظه الله ورعاه، أصحاب السعادة، مدراء الدوائر الحكومية، الإخوة والأخوات الحضور، أيها الحفل الكريم، السلام عليكم ورحمة الله وبركاته. يطيب لنا ويسعدنا أن نرحب بكم في هذا المؤتمر الدولي الأول للكشف المبكر عن سرطان الثدي، والذي جاء برعاية كريمة من صاحب السمو الملكي الأمير سعود بن نايف بن عبد العزيز آل سعود أمير المنطقة الشرقية يحفظه الله ويرعاه، وبحضور وتشريف من صاحب السمو الأمير بدر بن محمد بن جلوي آل سعود محافظ محافظة الأحساء حفظه الله ورعاه. يأتي هذا المؤتمر لما يشكله الكشف المبكر عن سرطان الثدي من أهمية بالغة في الحد من انتشاره، وكذلك الكشف المبكر له في مراحله الأولى، الأمر الذي ينعكس إيجابياً وبصورة متميزة على نسب الشفاء فيه، وكذلك الحد من تطوره إلى مراحل متقدمة. تأتي مشاركة الأحساء في مثل هذه المؤتمرات لما تميزت به من رغبة جادة في تطوير أساليب العلاج وكذلك الكشف المبكر عن الأمراض. إن هذه المشاركات من الأحساء لها الأثر الكبير، وهي أحد المتصدرين في محافظات المملكة ومناطقها في الكشف المبكر عن الأمراض بشكل عام، وخاصة سرطان الثدي. هذا المؤتمر يأتي بمشاركة من علماء وأطباء من دول العالم، من أمريكا وكذلك من بعض الدول الأوروبية، بالإضافة إلى الدول العربية والخليجية، وكذلك مشاركة المتميزين والمتخصصين من المملكة العربية السعودية، وخاصة محافظة الأحساء، والتي أصبحت لديها الخبرة الكافية والبناء المتكامل في مثل هذه الأنشطة العلمية، بتعاون جميع الجهات سواء من الشؤون الصحية من الزملاء والإخوة في جامعة الملك فيصل وجميع المؤسسات الحكومية والخاصة. نسأل الله العلي العظيم أن ينفع بهذا المؤتمر وأن يوفق الجميع لما فيه خير للبلاد والعباد، وكذلك نسأل الله العظيم أن يمن بالشفاء العاجل لجميع مرضانا وجميع من لديهم أي مشاكل صحية. ختاماً، نتوجه بالشكر الجزيل لصاحب السمو الملكي الأمير سعود بن نايف أمير المنطقة الشرقية على رعايته لهذا الحفل، والشكر موصول لصاحب السمو الأمير بدر بن محمد بن جلوي آل سعود محافظ محافظة الأحساء على حضوره وتشريفه لنا ودعمه اللامحدود والغير مستغرب منه لصحة الأحساء وجميع الدوائر الحكومية بالمحافظة. نشكر كذلك اللجان المنظمة بصحة الأحساء وكذلك جمعية مكافحة السرطان، والشكر موصول لإدارة الكشف المبكر عن الأورام وجميع الجهات المنظمة وجميع الجهات الداعمة لمثل هذه المؤتمرات. كما لا يفوتنا أن نشكر الإخوة الزملاء المحاضرين وكذلك الحضور لدعمهم وتواجدهم معنا، سائلين المولى عز وجل أن يجعل ذلك في ميزان أعمال الجميع وحسناته. والسلام عليكم ورحمة الله وبركاته.
أيها الحفل الكريم، يتفضل الآن صاحب السمو الأمير بدر بن محمد بن جلوي آل سعود محافظ الأحساء بإلقاء كلمته.
الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. أصحاب الفضيلة والسعادة والضيوف الكرام، السلام عليكم ورحمة الله وبركاته. في كل بلد تعتبر الخدمات الصحية عنوان التقدم والنهوض بصفتها تعنى بحياة الفرد والمجتمع، وفي مملكة الإنسانية يلقى هذا الجانب من الرعاية والاهتمام مع ما جعله على رأس قائمة المنجزات، حيث ترصد له الدولة ميزانية سنوية لتنمية قطاع الصحة بأرقى الخدمات المتطورة ذات الطابع التخصصي، وسعيا لسد الاحتياج وتلبية متطلبات العلاج العصري للعديد من الأمراض، وتكفل له من المباني والأجهزة والكوادر ما يحفظ صحة المواطن ويوفر عناصر الوقاية والتوعية والعلاج على حد سواء. وما هذه إلا دلالة واضحة على مكانة هذا المواطن في نفوس المسؤولين والدولة، حيث سعت الجهات المختصة المتمثلة في وزارة الصحة وإداراتها المنتشرة في ربوع المملكة إلى توفير جميع وسائل العلاج والرعاية الصحية لكل شرائح المجتمع. ونحن نشكر القيادة الحكيمة تحت مظلة خادم الحرمين الشريفين وولي عهد الأمين حفظهم الله على توجيهاتهم السديدة التي من خلالها يجد المواطن الرعاية والاهتمام، ويحظى المجتمع بخدمات صحية متميزة لتحقيق الأهداف السامية في خدمة الوطن والمواطن. ويأتي مرض السرطان بأنواع مختلفة في مقدمة الأهداف الرامية لتعزيز جوانب العلاج للمواطن السعودي وضروريات التوعية للكشف المبكر عن تلك الأمراض، فعمدت على فتح العديد من المراكز المتخصصة ذات الطابع العلاجي، ولا زال يمضى قدما في التوسعات ضمن الخطط المستقبلية. والأحساء تطلق اليوم جانب من رسالتها الوطنية لندشن المؤتمر الدولي الأول للكشف المبكر عن سرطان الثدي بين الحاضر والماضي، والذي تنظمه إدارة الكشف المبكر عن الأورام بمديرية الشؤون الصحية بمحافظة الأحساء. وعبر هذا المؤتمر نؤكد التكاملية في العمل والتعاون في الوسط الطبي للوصول إلى نتائج إيجابية ذات طابع بحثي متطور تخدم البلد المعطاء عبر تبادل الخبرات وتقديم نتائج البحث العلمي وما توصل إليه العمل في مجال أمراض السرطان. ومن هذا المنبر أنقل لكم تحيات صاحب السمو الملكي الأمير سعود بن نايف بن عبد العزيز أمير المنطقة الشرقية، فله الشكر والتقدير على رعايته الكريمة ومتابعته الدؤوبة لما هو صالح للمواطن والمنطقة. وأخيرا بارك الله في جهودكم وأعانكم على الخير، ونسأل الله العلي القدير أن يبعد عنا وعنكم الأمراض والأسقام ويرزقنا صحة دائمة وعافية طيبة، والسلام عليكم ورحمة الله وبركاته.
كل الشكر لصاحب السمو الأمير بدر بن محمد بن جلوي آل سعود محافظ الأحساء على هذه الكلمة الضافية. الحفل الكريم، جاء الآن وقت التكريم. بروفيسور كويك سوي تيان، بروفيسور أبيجيل سوزان كاودلي، الدكتور كريستوفر جوهانز ماريا دي وولف، الدكتور عبد الرحمن إبراهيم محمد فخرو، الدكتور أحمد صالح شملان، الدكتورة صالحة محمد جاسم بوجسوم، الدكتورة فاطمة إبراهيم سعود الهنان، الدكتورة ليلى محمد عبد الفتاح أبو طاحون، الدكتورة بروفيسور فاطمة الملحم، الدكتورة سميرة السليماني، الدكتور صالح العثمان، الدكتور صالح قباني، الدكتورة هيفاء نصري، الدكتور إبراهيم الشنيبر، الدكتور عبد الرحمن صالح الملحم، الدكتورة إيمان باروم، الدكتورة تهاني القرشي، سعادة مدير الشؤون الصحية بمحافظة الأحساء الدكتور عبد المحسن الملحم، الدكتور عمر بايمين مدير إدارة الكشف المبكر بصحة الأحساء، الأستاذ عبد العزيز الأمير مدير إدارة التدريب والابتعاث، جمعية مكافحة السرطان الخيرية بالأحساء الأستاذ محمد بن عبد العزيز العفاري. شركاء النجاح جامعة الملك فيصل، أمانة الأحساء، هيئة الري والصرف بالأحساء، إدارة التربية والتعليم بالأحساء، غرفة الأحساء، هيئة الإذاعة والتلفزيون، مستشفى الموسى التخصصي، مجموعة الحسين والعفالق، مجموعة أسهل للتجارة، جريدة اليوم، الهيئة العامة للسياحة والآثار، ختاما نشكر لصاحب السمو الأمير بدر بن محمد بن جلوي آل سعود محافظ الأحساء على تشريفه هذا الحفل. شكرا للجميع وإلى لقاءات أخرى مباركة بإذن الله، والسلام عليكم ورحمة الله وبركاته.
It's a great honor and pleasure to thank and welcome all of you for the attendance of the first conference on breast cancer screening, present and future. That's organized by Al-Hassa General Directorate, represented by Tumors Early Detection Administration. That's held under the patronage of the Royal Highness Prince Saud bin Naif bin Abdulaziz Al Saud, the Governor of the Eastern Province. In fact, this scientific gathering, abounding with the presence of a huge number of great doctors and scholars from all over the world. They all came to provide all the creative and new issues on breast cancer screening field. This scientific gathering focused on the most new studies related to the early detection and screening of the breast cancer, as considered the most common cancer and the major reason for the death in women. At the end, we are hoping to achieve a new step in the early detection and screening of breast cancer. Welcome again, and we will start with the first session directed by Dr. Tahani Al-Qurashi, a breast surgeon on National Guard Hospital, and Dr. Ibrahim Schneber, a surgical oncologist, King Abdulaziz Air Base Hospital, Dhahran. Thank you again.
Assalamu alaikum. Good morning, everybody. We like to start the first session, and it's my pleasure to invite Dr. Saleh Al-Athman. Dr. Saleh Al-Athman is a medical oncologist from King Faisal Specialist Hospital in Riyadh, and he's the assistant director for the Gulf Center for Cancer Control and Prevention, and he will present to us global and regional burden of cancer. Dr. Al-Athman.
Assalamu alaikum wa sabah al-khair. Dear gentlemen, ladies and gentlemen, in the beginning I would like to thank the organizer for inviting me for this great meetings, and I would like to share some of our data with you. I will start by this fellow chart, which was suggested by the WHO in how to decide if an early detection program is needed within the cancer controls. First thing, they suggested that cancer epidemiology analysis in the country or the region should be done, then to identify the main cancer type in the country and report the incidence, mainly of staging and mortality. Next, we have to ask, are there curable cancer among the most common cancer types? If no, improve palliative care and work in prevention. If yes, then we have to ask, are the majority of the curable common cancer presented in advanced stage 3 or 4? If no, monitor ongoing early detection and activity. If yes, then we have to ask, are there an early diagnosis or screening activities going on? If yes, we have to follow up and monitor. If no, we have to ask, is there resources? If no, develop a plan for early diagnosis. If there is resources, we have to develop a plan for early diagnosis and evaluate the visibility of screening, mainly in cervix and breast and colon. I'm going to consist in my talk about the first 4 parts. First, the cancer occurrence in worldwide. It is more than 60% of the cancers. It will be occur in the developing countries. Cancer cases worldwide increased from 7.4 in 2004 to 14.1 million in 2012. The estimated number of new cases of cancer each year is expected to continue to rise. In regard of the breast cancer incidence worldwide, according to the IRAC, in 2012, 1.7 million women were diagnosed with breast cancer. Since 2008 to 2012, breast cancer incidence increased by more than 20%, while mortality has increased by 14%. Breast cancer is also the most common cause of cancer death among women. When we look to the map, we find that the incidence of breast cancer, it is the first one in it is in 145 countries, followed by cervix in 37 countries, and thyroid in only 2 countries. What about cancer in the Gulf countries? Just so I'll give a brief idea about the Gulf countries, it consists of 7 countries: Saudi Arabia, Kuwait, Bahrain, Qatar, United Emirates, and Oman and Yemen. These countries share a lot of things: religion, language, culture, even health problems. Diabetes, it is one of the big problems in the region. But there is some variations in the cancer incidence, as we're going to see later on. Between January 1998 and December 2009, we reported total of 119,000 cancer cases. There was 58,000 male and 60,000 female. And there was increase in 1.4 folds between 1998 to 2009. We did projections, and we are expecting by 2030 we'll be having more than 21,400 total, and female will be more than 11,000 cases a year, by increase 1.4 folds. And female will be increased by 1.9 fold. When we look to the most, common cancers in male and female, we find colorectal cancer. It is the most common in male, followed by non-Hodgkin lymphoma and leukemia lung. But when we look to the female side, we find the breast cancer. It is the most common, with 24.2% of all malignancy, followed by thyroid and colorectal. Breast cancer incidence continue to increase over the 12 years period between 1998 and 2009 in the GCC women, and it was increased by 1.4 folds. The ESR was in 1998 15.5, in 2009 it was 25.6. Okay, different types of the breast cancers among different countries. The total over the period was 14,700 breast cancers was diagnosed. We see, in the top, the most common, it is in Bahrain by ESR 55.9, followed by Qatar and Kuwait, ESR 50. And the lowest was Saudi Arabia and Oman. Saudi Arabia 16.9, Oman 18.6. When we compare the GCC countries with another 10 other countries from Europe, North America, Africa, and Asia, we find Bahrain, Qatar, Kuwait come, on the top, the Western countries. While in Saudi Arabia, it came in the bottom. It's the lowest incidence. Staging, it is an important, and so advanced stage, over the 12 years, we find that it is around 58% of the breast cancers was diagnosed at advanced stage, either distal metastasis or local metastasis. And as we know, this is play a very important role in survivals and in treatments. Cancer in Saudi Arabia. When we look to the, cancers in Saudi Arabia over the 12 years, it is again, from 1998 to 2009, it is increased by 1.7 folds, and we did the projections, and we're expecting to increase by 2 folds in 2035, and the number we might reach in 19,930. But this is the complete picture? We didn't think so. Maybe things will be worse. For first reason, it is the nature of the populations. When we look to the stages of the populations, the 4 phases, we find Saudi Arabia come in the stage 1, in the first stage, and the other side, in the other part, that it is the UK populations. So with X generations will be with that one. And it is well known that aging, it is playing major factors in the development of cancers. So the number will be, expecting it will to be more. So are we ready for that? Okay, when we look to the breast cancer, again for the same period, we find, the breast cancers, it is the first one, it is the commonest with 22.4%, followed by thyroid, then colorectal, non-Hodgkin lymphoma, and leukemia. And the trend shows that is increasing, the incidence increasing by 65%. We did the projections, and we expecting the breast cancers by 2035 will reach to 3,248 by the year of 2035. Okay, when we look to the breast cancers, breast cancers and age specific, so we find that most of the cases it is below 50s. 58% of the breast cancers, it is below 50s. While it is in UK, the reports show in UK in 2011 there were almost 50,000 breast cancers among female, and only 9,700 cases were aged below 50s. And more than 80% were over 50s. So in the other countries, it is most over 50s, while in our country, in Saudi Arabia, it is among young ages. According to the Cancer Research UK, the vast majority of the breast cancers was in UK was diagnosed only by symptoms, since most of women aged 25 to 49 are too young for the routine breast screening. Okay, staging, presenting the cases presented usually again in Saudi Arabia at advanced stage, either local metastasis or distal metastasis. Around 60% of the cases presented with advanced cases. When we look year by year for the 12 years, unfortunately, there is really no significant improvement. Although it is, the region, the local disease was increased by 10% from 1998 to 2009, but still really need to be improved. Okay, cancer and air pollutions in Saudi Arabia. This is the map of the nitrogen dioxide taken by satellites in Germany, showing by the cities. It shows the most population cities in Saudi Arabia. It is in the eastern part, in the central in Riyadh, and in Mecca. Dr. Ali Zahrani with his colleague in the GCC, they did growth incidence rates in all cancers, in the gas densities. In the first, in the top show the most common cancers within the cities. The lower maps, it show the concentrations of the gas, and we find that we can see that from the maps, it is most common cancers, and the high concentrations is mainly in the eastern part, in the central, and in Mecca. When we look to the regional distribution of female breast cancer in Saudi Arabia, it is the most common, it is within east part of Saudi Arabia, followed by Qasim, then Riyadh, then Mecca. And they did, a correlation and association between the nitrogen dioxide concentrations and the breast and they find that there is high association between breast cancer and lung cancer incidence. So now we will look to the access to the specialized cancers in the care. So now we define that it is most common in the east, in the central, and in Mecca. This map show the cancers distributions in the left sides, most common cancers, and in the right side it shows the distance between the tertiary hospitals or the specialized hospitals where patients can be treated. The red color, it is more than 5 hours of traveling, and the blue less than 1 hour. The median travel time to the closest specialized cancer care facility was almost 3.5 hours. Residents in the north and southern geographical regions, they take longer times to travel to be treated there. In summary, Breast cancer is the most common, most female cancer in the GCC, account for 24.2 from all female cancers. Breast cancer increased by 1.4 between 1998 and 2009 in the GCC. In Saudi Arabia, breast cancer is the commonest female cancer and account for 22.2%, and expected to increase by 2-fold in 2035. Advanced breast cancer presented in 58 of cancers, either regional or distal metastasis, both in the GCC and in Saudi Arabia. More than 58% of our patients get breast cancer before the age 50. Mortality and treatment costs become higher when breast cancer is diagnosed at late stage. There is high correlation observed between nitrogen dioxide concentrations and breast and lung cancer incidence. The 5 regions with the highest ESR were Eastern Qasim, Eastern Bath and Qasim, Riyadh, Mecca and Medina region. Residents in the north and south of geographical sectors had longest travel time to go to to be treated or to be seen in the specialized hospitals. Conclusion, only prevention can reduce cancer incidence, and only awareness and early detection can improve survival rate. Individuals must take more responsibility for their health by awareness. Evidence-based guidelines for early detection improve survival. Integrated patients centers approach between primary, secondary, and tertiary healthcare services is needed. Health service must be organized at a regional and national level to ensure efficiency and maximize use of resources and bridging the gaps. Cancer control and prevention can be only if it's fully bridged between the health service system, society, and health service system. In the Gulf Center for Cancer Control and Prevention, we starting, since it is developed in 2011 in preventions, now we're trying to encourage countries in the GCC to put more restrictions in smoking and to encourage healthy foods, mainly in the schools. Also, we're trying to encourage governments and NGOs to give more efforts to public awareness. Also, we are now working in evidence-based guidelines for screening. Also, we are working in evidence-based guidelines for treatment. Also, we're putting program to encourage governments to invest more in palliative care and training and research in cancer. By the way, we're having an international conference which will be held end of October under the title Burden of Cancer in the Gulf Region, Bridging the Gaps. So you all welcome and invited. And this is the web page if you would like to log in and register. Lastly, I would like to thank Dr. Khoja, Dr. Ali Zahrani, and Mrs. Amal Al-Maj'un. And also I'd like to thank the GCCB Advisory Board from Saudi Arabia, Dr. Samar, Dr. Al-Jifri, Dr. Al-Hibshi, Dr. Bazarbashi, and Dr. Khalid Al-Saleh from Kuwait, Dr. Khalid Al-Saleh, and Dr. Al-Khaldi, and Dr. Ahmed Al-Awadi. From Bahrain, Dr. Al-Awadi and Dr. Amal. From Oman, Basim. And from Emirates, Dr. Muhammad and Dr. Nada. From Qatar, Dr. Al-Khatir and Dr. Al-Hussein. From Yemen, Dr. Ahmed and Dr. Afif. Lastly, thank you very much.
Thank you, Dr. Saleh, for this interesting presentation. The door is open now for question, please. And if anybody have any question? No question?
No question.
Thank you, Dr.
Thank you.
I'm so pleased to be with you today and to have the chance to present our next speaker, Dr. Ibrahim Al-Schneber. He's a consultant surgical oncology at Armed Forces Hospital, King Abdulaziz Air Base, Tehran. He graduated from King Faisal University in 1983, and he completed his surgical training in McGill University, Canada, in June 1994, and he had fellowship in surgical oncology from the same university, McGill University, in 1996. He had diploma in healthcare quality, Oklahoma University, USA, and he certified in profession in healthcare quality, National Association for Healthcare Quality from USA in October 2004. Please join me in welcoming Dr. Ibrahim Al-Schneber.
Thank you, Dr. Tani. Dr. Khalid Saleh from Kuwait has asked me to present this presentation on his behalf because for unforeseen circumstances, he could not come. So the day before yesterday, he sent me his presentation and he asked me to present it. So it's his work, but I thought I'll just give you a brief idea about his presentation about breast screening program in Kuwait. So they look at breast cancer burden in Kuwait with three important factors. They look at the incidence rate. Is this cancer prevalent in their area? And is it common in young women? And what is the tumor volume when these patients present? So if you look at the slide, you see that there's an increase in the breast cancer incidence in Kuwait from 1985 to 2010. It was 22, then became 30, and then 48, and then 61. So the incidence of breast cancer is increasing in Kuwait. And when they looked at the median age of women with breast cancer in Kuwait, it was 44.5 compared to 59.8 median age of women with breast cancer in the West. Also in another statistics, 47%, about half of women with breast cancer, they are less than 50 years old in Kuwait, and actually 30% of them are even less than 40 years. 41% of breast cancer patients in Kuwait present with a cancer tumor more than 7 centimeters. And this occurs in less than 10% in European countries and about 8% in the US. So there is higher incidence of an high tumor volume in Kuwait. Presentation, 64% of breast cancer patients present with local advanced disease, while local advanced disease occur only in 20% in Western countries. What are the reasons for late presentations of breast cancer in Kuwait? Well, they think it's because of lack of awareness and information about breast cancer, because of misconception about breast cancer, and misunderstanding about the seriousness of breast cancer. There is also a delay in the treatment of breast cancer in Kuwait. 43% are treated late, while in the Western countries, about 13%. So in Kuwait, breast cancer is increasing. There is a delay in the presentation and in the treatment. The age of presentation is younger compared to the Western countries, and the tumor volume is bigger also compared to the West. So there is a need for a quick improvement and an action plan. And the aim of the plan is to improve awareness level and to decrease the late presentation of breast cancer and detect breast cancer earlier in order to improve survival. In February 1999, first early detection of breast cancer committee has been established, headed by the Assistant Under Secretary of Ministry of Health. The committee reported to the Minister of Health the need to start the awareness program. This was in 1999. In October 2001, committee started in Kuwait Society for Smoking and Cancer Prevention, this is a non-government organization and not related to the Ministry of Health. So between 2002 to 2006, there was no active action by Ministry of Health for screening or awareness. It was only scattered efforts by the NGOs, non-government organizations. On March 2006, National Committee for Cancer Prevention has been established and protocol of action has been made, and final report was given to the higher authorities. In 2007, the National Cancer Program was established. So from the recommendation in 1999, Ministry of Health responded in 2007. So there is a delay not only in the patient's presentation, but also in Ministry of Health action. The aim was to reduce the incidence rate and to look to discover the risk factors and try to manipulate them to decrease the incidence, like postmenopausal obesity, the delayed marriage, and the late delivery, because as you know, nulliparity is a risk factor for breast cancer, and to do genetic mapping or genetic screening and education and awareness, and to try to encourage women to get married early and to deliver early. Category 1 awareness, the goal is to raise the awareness level of the public and encourage them to adopt a healthy lifestyle. And the program was focused on breast cancer, and at that time they decided to also join that with prostate cancer because they are common, and in order to treat both men and women. This will be implemented through workshops and presentations. Awareness at schools also, focusing on high school girls, and nearly 40,000 girls from high school students were trained self-breast examination. The principles of breast screening, situation analysis, evaluation of the manpower and budget concerns. So situation analysis regarding incidence patterns of breast cancer, regarding the different programs and comparison between them and their effectiveness, the awareness, the educational, the training, and so on, and then to implement an acceptable practical strategy. With regard to manpower, you have to make sure that you have pathologists, health expertise, clinical oncologists around for the program, and even before that, you have to have expertise in reading the mammograms. And you must, of course, make sure that you have the budget and the resources in order to put down a strategy and implement it. Their vision was to provide breast screening for all women in Kuwait after a positive result from the pilot study, and to provide integrated approach of awareness and education and training and screening, starting as a pilot study. 5 clinics were equipped, and they in each district, and they started awareness and encouraging women to visit their local clinics with the plan to generate statistics based on the data collected. The clinic started only last month, April 2014, as a pilot study. So first report will be in December of this year, And the pilot study, they think that it will confirm the importance of screening program and its effectiveness in Kuwait. And then they will, based on that, they will recommend a full screening program for the whole country. Because they think that there are some studies that are controversial about the effectiveness of screening mammography, although there are some other research showing that there is a decrease in mortality, as we all know, and a better survival with screening mammography. So they want to address this problem, and they want to make sure that in their country and in their culture, that screening mammography is effective before they make it generalized for the whole country. National Breast Screening Program is still a controversial issue. In Kuwait, as a breast cancer affected younger age and high incidence rate pilot study is required to evaluate the effective national screening program. And thank you.
Thank you, Dr. Ibrahim Schneiber. Any question for Dr. Ibrahim? Thank you, Dr. Ibrahim, again.
Okay. Thank you. If you don't have any questions, so we come to the conclusion of this session. Thank you very much.
Excuse me. We are going to start the second session for this conference. I hope all the audience outside to come inside the main hall here, and we'll start the first lecture in this session with Mr. Quick Sweetian. Please come.
Thank you, Mr. Chairman, for your kind introduction, and a very good afternoon to all of you. I would also...
Yes, few words you will talk about you to introduce you.
Oh, okay, sure.
Good afternoon. Now we'll start the second session of the first day, the afternoon session. We are proud to invite Dr. Quick Sweetian. He's the director of the breast screening program, National University Health System in Singapore, and he's the head of the radiology department of the National University of Singapore. He had MBBS from the National University of Singapore, fellow of the Royal College of Radiology from United Kingdom, and he fellow of the Academy of Medicine from Singapore. He is member in a lot of, in many national and international institutes, and he had more than 25 top publications in the different international journals, and he contributed in many textbooks. Dr. Quick, please.
Thank you, Mr. Chairman, for your kind introduction, and a very good afternoon to all of you. I would also like to express my appreciation to the organizing committee for the kind invitation to speak here. It is a great honor and privilege for me to share with you the breast screen experience of Singapore. What I hope to do is to take you briefly through why Singapore started a national breast screening program, and I will also take you through how we run the program, and finally I will share with you some of the lessons we've learned along the way. But for a start, I'm not sure how many of you are familiar with Singapore, so I thought a bit of introduction there may be useful. Now this is where we are at the moment. We are in your lovely country of Saudi Arabia, and we are somewhere along the eastern province. Now this is Asia, and Singapore is in the southeastern part of Asia, just south of Malaysia. This is a satellite image to show you Singapore. That's Malaysia there, and this is the island of Singapore. And we are actually a very small island, only about 25 by 50 kilometers. And within this small island of about 700 square kilometers, we have a population of 5.3 million, which makes us one of the most densely populated countries in the world. Now, if you look across Asia, there are no other national screening programs. And now, why would a small country in Southeast Asia start a national breast screening program? For that matter, what are the indications for starting a screening program in any disease? Well, if you look at the WHO recommendation, they state that screening program should only be undertaken when their effectiveness has been demonstrated, when resources are sufficient to cover nearly all the target population, and when facilities exist for confirming diagnosis and treatment and for follow-up of those with abnormal results. And most importantly, when the prevalence of the disease is high enough to justify the cost and effort of screening. Now, this is a map of the incidence of breast cancer worldwide. And you can see that in certain countries like the States and Canada, most of Western Europe and Australia, it has a high incidence. But what about the Gulf countries and Asia? If you look at the Gulf countries here, it has a moderately high to high incidence of breast cancer. But for most of Asia, the incidence is actually fairly low. Now, I say most of Asia because if you look here in Japan, in Korea, and in this little island of Singapore, we have quite a high incidence of breast cancer. In fact, if you look at the incidence of breast cancer in Asia, Singapore ranks quite high in terms of the incidence. And some of the other Gulf countries follow quite closely behind, like Kuwait and Qatar. Now, when we look at the most common cancers in Singapore women, breast cancer was not only the top cancer, but it accounted for almost 1/3 of all cancers in Singaporean women. Now, when we talk about cancer, we not only look at the incidence, but we also look at the trend and the outcome. In terms of trend, it was fairly alarming. Back in the 1970s, breast cancer was our top cancer, followed by cervical and stomach cancer. Now, over the years, you can see that the incidence of cervical and stomach cancer has dropped, while that of breast cancer has increased almost exponentially. In terms of outcome, I think cancer mortality is a good way of looking at it. And breast cancer, again, tops the causes of cancer death in Singaporean women, with 1 in 6 Singaporean women dying of breast cancer if it is due to a cancer death. Now, so when we look at our strategy for reducing cancer mortality, breast cancer screening became quite important. Now, prior to all this, we had been doing screening, but it was based on an opportunistic pattern. What we did was the women would see their general practitioners, and if the general practitioners felt like it, they would refer women for screening. And the question then was, should we move on to a population-based screening? And of course, the other question that arose is, has the effectiveness of mammographic screening been demonstrated worldwide, and more importantly, in Singapore? So when we look at these issues back in the 1990s, basically, there was evidence that breast cancer screening was useful in reducing cancer mortality. And even as recently as 2012, when an independent UK panel looked at the effects of breast cancer screening, they did a meta-analysis of 11 randomized trials, and they concluded that there was a relative risk reduction in cancer mortality amongst women invited for screening by about 20%. Our concern was more something that was brought up by some of the other Asian countries. Basically, it was felt that Asian breast tends to be very dense. And there were reports coming out from mainly Hong Kong that queried the effectiveness of breast cancer screening in Asian women because the breasts were fairly dense compared to Caucasian women. And they suggested that screening may be less effective in Asian women. So to look at this, we actually did a breast screening project where we followed 160,000 patients for a number of years, and we randomized them into patients who were subjected to screening and those who were just followed up. And we looked at a cancer detection rate. Well, we had about 4.8 cancers detected per 1,000 women screened in the screen group compared to the control group. And more importantly, the majority of cancers detected in the screen group were relatively early stage cancers. About a quarter were DCIS, and about 40% were stage 1 cancers. And the risk of stage 2 or later cancer was only half that of the control group. And all this was achieved at a recall rate of 8% and a biopsy rate of 1%, which was considered acceptable. So based on this, we thought that screening mammography was a useful modality for detecting early breast cancer, even in Asian communities where there was concern about the density of the breast. So based on the high cancer incidence rate, the fact that it was the top cause of cancer death in Singapore, and the results of this project, we embarked on a national screening program in 2002, and we called that simply Breast Screen Singapore, or BSS for short. Now, basically, we invited women above the age of 50 for screening, and they were screened once every 2 years. Women from the age of 40 to 49 were not invited, but they could enroll in the screening program if they wanted, and they were screened annually. And the ones that were excluded from the screening program were women who were on active surveillance post-breast cancer treatment, women below the age of 40, and those with a silicone oil injection. Sorry. Now, so in terms of the BSS, where did we screen and what did we do for screening? Now, basically, as I showed you earlier, Singapore is a very small country. But even within this small country, we set up 16 screening centers all around the country to make it accessible to the patients. The screening centers were housed in what we call polyclinics. These are government-run clinics, and they were housed by about 15 to 20 or more family physicians. And the key to the polyclinics is really in their location. If you look here, peeping up from the background, there is a block of flats or apartments here. Now, as I mentioned earlier, Singapore is a densely populated country, and about 90% of the population will stay in apartment blocks like these. And the polyclinics were housed within these apartment blocks, so it made them very accessible to patients. And therefore, you find that the attendance at the polyclinics were very good. They were usually very crowded. Now, in terms of screening, we did a 2-view mammogram. And at the time of screening, we would also teach the patient how to do breast self-examination. Now, after the screening was done, the mammograms were sent to 5 reading centers, and these were all hospital-based centers. There were certain requirements for radiologists to get onto the Breast Screen Singapore program, which I will talk about later. But the key to the reading was that all the mammograms were independently double-read, because this has been shown to increase the pickup rate for cancer. So if both readers were concordant, that's not an issue. But if there's discordance between the 2 readers, meaning one said that it was normal and another said that it was abnormal, it would go on to a 3rd reader who will then decide whether to recall the patient or not. Now, in terms of the requirements for the radiologists, we set fairly simple standards. They had to do at least 1,000 screening mammograms a year. They had to have ongoing experience in BSS assessment clinics, which I will touch on later. And they also had to attend multidisciplinary meetings as well as quarterly breast review meetings, which I will also touch upon later on. But most importantly, every single reader was subjected to the reading outcome audit. So the results were entered into a simple form like so. So if it is normal or benign, they were not recalled, they just went for routine screening. If it was indeterminate, or if it was suspicious or malignant, they would be recalled for further assessment. And of course, if they had silicone injection, they were out of the program. Now we switched from an hard copy system to an online system, but basically the data entry was similar. So basically, if a woman went for the breast screen, and if it was normal, they will receive the result in the form of a letter telling them that that was normal, and they would go back to the pool for rescreening. If, however, it was an abnormal mammogram, they would go to one of 3 designated centers for assessment. So these are the 3 centers, and they will receive a letter telling them to make an appointment within 2 weeks to at one of these centers. We would also tell them a little bit about what to expect. We could be doing additional views or breast ultrasound. And because many of these women who are recalled for assessment are highly anxious, we also give them a hotline number to call, and this is manned by a nurse advisor who could speak to them and tell them what to expect at the assessment if the woman wanted to know more about it. Now, at the assessment process, what happens? Well, most of these assessments attend because of abnormal imaging finding. So the assessing radiologist will review the screening mammograms and decide what additional imaging may be required. This could be magnified views or an ultrasound or a combination of these. Now, of all the women who attend assessment clinics, about 2/3 to 3/4 of them will be discharged as normal or benign cases. They could present with an apparent distortion that is not real, or they could have a simple cyst or a very typical looking fibroadenoma, and these would go back to the routine rescreen. Of the remaining women, they would require a biopsy. And for women who required a biopsy, they would be seen by a surgeon at the same assessment clinic, and they will undergo clinical examination, and if needed, they would go for additional imaging. Now, a small number of patients with normal imaging may also be seen at the assessment clinic, and these are the symptomatic patients. So at the time of breast screen, they are asked by the radiographer whether they had a breast lump or nipple discharge, and if they did, they will recall directly to the assessment clinic. So as with the reading, assessment data was entered into an online system, whether the patient had a mass, whether it was calcification or architectural distortion, and we would have different data entry if they had mammograms or ultrasound, and then we will have a column for the imaging results. If the patient needed biopsy, the clinical assessment would also be entered online, and finally we would have the recommendation whether the patient needed a biopsy or whether they went back for routine rescreen. Now, the online system takes a bit of time. It is more tedious and you need very good IT support, but the advantage was that it could help us generate data more easily. So for women who needed a biopsy, almost all of them will get the biopsy performed on the same day. And that's because the majority of these women are very anxious, and if you tell them they have to come back in a week's time for a biopsy, they tend to freak out. So we tend to do all that within the same assessment day, and then they are given an appointment to return to assessment in 1 to 2 weeks' time. Now, what happens in this 1 to 2 weeks? Well, for a start, it takes a couple of days for the results to come out, and then all cases of the biopsy are reviewed at a multidisciplinary breast tumor board like what you see here. And the people attending the breast tumor board would be surgeons, radiologists, pathologists, medical and surgical oncologists, and nurses. And we will review the biopsy, make sure that it was adequate, and we will review the outcome of the biopsy and decide on management. So if the biopsy was benign and if this was concordant, it goes back to routine rescreen. If the biopsy was a malignant case, the surgeons and the oncologists will decide on the further management of the patient. And quite importantly, we also look at discordant results. So if imaging result is suspicious, but we end up with a benign biopsy, then we have to decide what to do with these cases. Do they go for another biopsy? And if they do they go for an image-guided biopsy, or should they go for an open biopsy? And generally, of the biopsies that we do, about 1 in 4 to 1 in 5 will have a malignant result. So basically, this is the workflow for Breast Screen Singapore. You find that the screening mammogram is done at 16 centers scattered around the island to make it convenient and accessible for the patients. The mammograms are then sent to 5 reading centers, and to qualify as a reader, the radiologist had to fulfill certain requirements. At reading, if this was normal, the patient goes back for a routine rescreen. If it was abnormal, the patient will be recalled for assessment. At assessment, if it is found to be normal or benign, the patient again goes back for routine rescreen. If it is indeterminate or suspicious, the patient sees a surgeon, undergoes a clinical examination, and then go for a needle biopsy. And after the needle biopsy, there is a case review at a multidisciplinary tumor board. And if the biopsy result is benign, again, this goes back to routine rescreen. If the biopsy result is malignant, definitive treatment is planned for. And in a small number of cases where we have high-risk lesion, like atypical ductal hyperplasia or radial scar, the patient may then go on for an open biopsy. Now, one of the key of any screening program really is the quality assurance, and we try to ensure this at various levels. So for a start, there are certain criteria for all professional staff, whether they are radiographers, radiologists, or surgeons, before they can be part of the breast screen program. And all biopsies, as I've mentioned, are reviewed at a multidisciplinary tumor board. For individual readers, they can look at their own recall rate, the breast cancer detection rate, and also their miscancer rate. And that is the advantage of having an IT system, because it can help you generate these reports. And very importantly, once every 2 to 3 years, we do an audit of every component of the breast screen program. So we will audit the screening centers, we will audit the reading centers, and we will also audit the assessment centers. And we will audit radiographers, radiologists, surgeons, and pathologists. So this is an example of some of the things that we audit. In this case, we are auditing the radiologists. We look at the number of reads that they do, and then we look at their assessment recall rate, as well as the eventual recall rate. And very importantly, we look at the program detected malignancy, as well as the patient-detected malignancy. So in this case, if you look at this patient, he or she read about 150, about 1,500 cases, and there were 5 cases of cancers, and the reader detected all the cancers. So that's not a problem. But if you look here, this reader read about 2,000 mammograms. There were 14 cancers in the 2,000 mammogram, and the reader only detected 12. So there was a so 2 cancers were not identified by the reader. So in these cases, we will find out what the 2 cancers are, and we will feed back to the reader so that they can relook at the cases and hopefully benefit and learn from the experience. So what are some of the lessons learned? Well, there are many lessons learned along the way, and we continue to learn new things every day. But basically, I will share with you a few of the more important ones. The first is in terms of equipment and infrastructure. As I've mentioned previously, it is very important to have a network of screening centers that is conveniently located and easily accessible to the patients. An IT system is also very important. And with the IT system, you find that you need very good IT support. Generally, in terms of equipment and infrastructure, they can be acquired relatively easily if there are adequate financial resources. The other issue really is that of manpower. You need to train enough radiographers, radiologists, and surgeons to man the screening centers, the reading centers as well as the assessment centers. And usually the manpower takes a bit more time to develop. The other thing is to note that screening does come with issues of its own. So these issues include false positive results. It will lead to a high level of anxiety amongst the patients, and they may get unnecessary investigation and biopsy. And there would also be the tendency for false negative results, in which case some patients may try to seek a false reassurance. What do I mean by that? Well, some patients will present with a breast lump, and they will enroll in the program and tell the radiographer that they have no lump. And they hope that if the mammogram is read as normal, everything is fine. And I show you one example of this. This is a 56-year-old lady who presented at first screen. And when the radiographer asked, "Do you have a lump?" her answer was no. But I'm sure a mass this size can be palpated quite easily. Now, the other important lesson that we learned was to work with the target population to gain their buy-in and acceptance for the program. Now, initially, we thought that by having screening centers that are convenient and easily accessible to the patients, they will come for the screening. But when we looked at our experience, this was not so. Only about half of all patients of all women who were invited came for screening. And they would give you various reasons not to come. They would say mammography is painful, or they were too busy. But basically, it's because they believed that they were at low risk or no risk of getting breast cancer. Or for some, they had a more fatalistic approach. They felt that even if cancer was detected, nothing much could be done about it. So as we noted in our breast screen project previously, there is a need for health education efforts that will focus on issues related to the acceptability of the screening program. So public education is very important, and we organize events like this Pink Ribbon event, or we organize events like a Breast Cancer Awareness Month to drum up the public awareness for breast cancer screening. And this has to be an ongoing effort. And of course, the political support is also very important there. So in conclusion, I've given you a simple insight into why we started a national breast screen program, how we run it, and shared with you some of the lessons we have learned along the way. Now, every country, every program will have its own unique set of problems, but there will also be some issues that are common across all screening programs. So I hope that what I've shared with you is informative and will be useful in your screening program. Thank you very much for your attention. Shukran.
Thank you, Dr. Quick-Sutian. And we'll make the lectures at the end of the sessions. Now we'll have a lecture in quality assured breast screening in Europe by Dr. Chris Johannes Maria de Wolf. Dr. Chris, he is a medical director of the breast cancer screening program in the canton of Bern. He's a director of Society Consulting and Auditing Breast Services. Worked on European breast screening strategies for 8 years. He was charged with the development of the European guidelines for quality assured in breast cancer screening and diagnosis. Head of screening and early detection at the International Union Against Cancer. Please, Doctor.
Thank you very much, Omar, for this introduction. And sorry for the misunderstandings with my name, because my last name is Dr. de Wolf. My first name is Christopher Johannes Maria, but okay, that's our cultural differences. I'd like to welcome you very much here, and I'm very happy that I can speak to you and share my experience with you about breast cancer screening. I will talk today about quality assured breast cancer screening, and I will give you an overview in short about mammography, what is diagnostic, what is screening mammography, why breast cancer screening, what are the EU quality assurance guidelines, screening in Europe, and current issues, about 5 points. but still I have to go back a little bit, some basic information. We all know that a cancer at a certain time, when it mutated and becomes a cancer and starts growing, it is an exponential growth. At a certain time, the cancer is not detectable. At one point, there is a limit of clinical detection. You can detect a cancer. The cancer can be about 1 to 2 millimeters big. That is the time that the cancer can be detected, and here there are clinical, somewhere here there are clinical symptoms, and then it can lead to the death of the cancer. You see also that the cancer, the exponential growth is not continuous. It flattens off at a certain time because of the nutrition factors, that the cancer cannot get enough nutrition to grow exponentially. Exponentially means if you have one cell, then it's 2, 4, 8, 16, 32. With each cell, if it divides, it adds exponentially. If you then look from what are the time that you can screen, I just told you that here is the time that you can detect a cancer, and there is the time that there are clinical symptoms. The time that you can screen is in fact the sojourn time. If you, in that sojourn time, the cancer can be detected by screening, and if you do a screening here, that is the lead time, is the time that you do the screening until there are clinical symptoms. Why is that important? Because also for that determines, in fact, the screening interval. But the second thing, what it is important for is there are also cancers which have a different growth rate. Some cancers grow very fast. These are the grade 3 cancers. Some are very slow. Some are growing until in stage that they can be detected, but are non-progressive. They can be probably, these are the cancers that are accounted for in overdiagnosis. If you then do a screening, you know you have to take this, in the sojourn time, you can, the screening should take place. So if you take a screening interval which is quite long, then it might be that you have a cancer that is developing and having clinical symptoms, but it has not been screened. Then you miss the cancer. You can also make the screening interval very short, and then you find all the cancers, but then it's also very expensive. And lastly, you have also to find a compromise in fast-growing cancers and slow-growing cancers. Some are growing so fast you will never find them in a screening interval. Some are growing so slow that you probably missed them the first time, but you find them the second time. That is some basic information. Another reason what I'm going to tell you here is why is screening important? And I don't have to tell you going to the clinical of the randomized controlled trials. There's also another way, and this is in fact the adjuvant online, which is used by many oncologists. I have taken here a fictive patient from 60 years with a grade 2 cancer, which is only 1 centimeter big. If you then see that only with surgical therapy, 98% of the women are still alive in 10 years. If I now look at the same patient, but then her cancer is 3 centimeters big, all of a sudden you see that only after surgical intervention, 67% is still alive. And here you see that only with the bigger cancer, the hormonal therapy and chemotherapy has an effect. Now I go to one step further, and this is the same size of cancer, but now she has positive lymph nodes. All of a sudden, only 60% is alive after 10 years, only after surgical intervention. This is also another proof from the SEER database in the United States that early detection does save lives just by detecting earlier. And that may count up even to 30% if when lymph nodes are affected between early stage cancers and late stage cancers. This is also known, and Don Barry in 2005 published this information. They did a modeling of what would be the effect of screening. And they say if we have nothing, we don't do anything, you see that the incidence of breast cancer will go up with the mortality. If you do screening, only screening, it will be flattening. And also that will happen if you do only adjuvant therapy. But only if you have screening and adjuvant therapy, you will be able to reverse, in fact, the mortality figures for breast cancer. It's also been told the size matters. I should have taken my English slide here, because I think most people do not read any German. But it says here that you can find small cancers up to 5 millimeters with mammography. 50 millimeters are normally found by a clinical examination. 25 centimeters if you do it yourself often, and 35 centimeters if women do not often self breast examination. And I found this image quite speaking when women are not facing the truth about breast cancer. When I talk about mammography, and also my previous speaker has been talking about opportunistic screening and organized screening, mammography can be used in several ways. You can do it in a programmatic way, in a systematic screening program, or do it in an opportunistic way that the woman requests herself the screening. You see there are quite some differences, but the most differences are in the level of quality. If you have an opportunistic screening program or a diagnostic screening, there is a variable quality. It's very much dependent on the person who is doing it. There is no double reading, it's peer review. The recalls are not known. It's very costly. You know, it's limited quality assurance monitoring, and in fact, most of what happens there is in a medical black box. Interval cancers are not known. Benign lesions that are called here are called in screening false positives, but both have also overdiagnosis. Why breast cancer screening? The purpose of screening is to advance the timing of diagnosis and thereby improve prognosis. Primary breast cancers do not kill. Metastatic breast cancers kill. And breast cancer is an important public health problem. Why? I have here some data from Switzerland, and why is it an important problem? If I look at the causes of death in all women in 2011 in Switzerland, for example, each year 32,000 women die on all ages. But you see in the age group 45-64, 2,700 die, and more than 15% dies of breast cancer. That's why breast cancer is also an important public health problem. It's not the problem that women die at the end of their life of breast cancer, but they die on a young age of breast cancer. And you see, this is an incredibly large amount of potential life years lost. If I see it, look in this scheme too, you see here the incidence is going up very steeply after a certain age. The mortality is also going up. But if I look at the proportion breast cancer towards all death, you see that the peak here is at a younger age, because most women, there are not many other causes of death in the young age of a woman. And if women die on this age, young age of breast cancer, that's a lot. That's counting for about 4,200 potential life years lost in Switzerland of these 500 who die in that age group. We know the disease has an early onset, so there are ways to do early detection. And many risk factors are also identified. Only a very few can be altered. I was struck by an information I read recently that the earlier menarche from women nowadays, from in the 50s, the average age for the first menarche for women was about 18 years. Now it has gone up to 13 years. Also with less pregnancies, women have in their lifetimes about 30% more ovulations. That means changing in their estrogen level, but may be a risk factor for breast cancer. And also radiation exposure. Radiation exposure, I have another slide that comes later. There are effective interventions and treatments. The benefits from screening should outweigh the physical and psychological harm. The cost of the screening should be economically balanced. And most important of all, women are concerned about breast cancer. They're worried well. About some ionizing radiation in the environment. We see that about half of our radiation is artificial, that comes mostly from medical devices. The mammography has only a very small proportion of radiation that counts on artificial radiation. The natural radiation sources are like some straling in Iran and in Brazil is very high. They have about 10 millisieverts a year. If people who are flying often high in the air in airplanes, they have also higher doses. But normally, this is about our average, what we achieve a year on natural doses. But I wanted to show here that mammography has a low dose, but also it might be, because I was wondering, why are there so many young women with breast cancer here, but that's also relative. Maybe that there is also a high background doses in these countries here. What is the public health aspect of screening? Why should the government be involved in a screening program? In my opinion, that is because public health screening goes beyond the existing patient-doctor relationship. It's not a responsibility only of the doctor. The doctor's opinion and contribution, the radiologist's contribution, is essential to a screening service, but it goes beyond his medical expertise, because mammography is not 100% sensitive and specific screening test. There are false positives. There are also false negatives in the screening program. And you cannot hold the doctor responsible for these mistakes. So it is a political choice to offer public health screening. And this choice can only be justified when the quality of the program meets defined standards. This was very important in Europe. Every country has taken a political choice to introduce screening, but they say we only accept screening if it meets certain quality standards. Also, it is if there is a political decision to offer screening, they have balanced the benefits and harms of the screening, also in relation to the overdiagnosis, interval cancers, or temporary increased levels of anxiety. I come now to the European guidelines, because I just told you that only politicians can accept a screening program if there are guidelines on quality assurance. In Europe, we started developing of the screening started about in 1990. Then at that time in Sweden, they had done the randomized trials. In UK, they had randomized trials. And in the Netherlands, they didn't have randomized trials, but they started in 1990 with screening. Also in that time, the European Commission had a program that was called Europe Against Cancer. And I was working in this program and charged with all setting up screening programs in Europe, especially on breast cancer, and develop European guidelines on quality assurance. I received that task in 1991, and in 1993 the first issue appeared, and this issue had mostly to do with the protocol on physical technical quality control. I'll come back to that tomorrow in my second speech. But what was most important when we started with this screening program, the intention was if you have quality assured guidelines, we try to protect participants from poor service quality. We promote evidence-based practice. We set minimal and desirable, achievable parameters. We raise standards to promote multidisciplinary teamwork, and it leads to specialization. In 1996, there was the second edition, and because we had set up a network in Europe with many different countries with pilots to do screening, we have realized we had to add information on epidemiology and pathology and on a revised technical protocol. The second edition was very important to promote the screening in Europe, and you see in 1989, we had, all of a sudden, in many countries, we had pilot projects. We had 2 in France, we had 2 in Brussels, 1 in Luxembourg, 2 in Spain, and in Germany. All these countries didn't have screening programs in the beginning of 2000. In 2001, we published the third edition of the guidelines. And what was important there, we also added quality assurance guidelines for radiological and radiographical issues and surgical management. Also in 2003, there was a European Parliament resolution recommending breast cancer screening to all their member states to achieve a 25% mortality reduction. In the same year, also, there was all the ministers of health of the European member states countries. They came with a recommendation, also again, recommending breast cancer screening based on the European guidelines. So in 2006, we published the fourth edition of the guidelines, also with information about communication, digital mammography, surgery guidelines. And all of a sudden, you see that it has been changing in Europe. In about 9 years' time, You see that France, Belgium has added screening, national coverage screening. You see that in Spain, you see this is Hungary, this is Czechia, they started screening, and you see they are all planning to do a national screening program. And in 2012, you see that almost all of Europe has national screening programs, organized screening programs. Austria started, in fact, this year. Switzerland is not a member of the European Union, but has still, in the German-speaking part, they are not screening. And you see here in the southern part of Europe, there's also not screening programs, they have no programs. But you see in 20 years' time, we have covered almost all of Europe with screening programs. Participation rates are very important in screening too. And around Switzerland, you see also in Germany that started relatively late, they have about 50%, in France 52%, and in Italy 54%. But if you go to other countries, like in the Netherlands, it's 80%, in Norway 75%, in UK 74%, in Spain 70%. There are some provinces in Spain that even reach over almost 90% of participation rates. That's very high. If you set up a screening program, we have to take many things in account. You have to look at the culture. You have to look at the political situation. You have to look at the social environment, the norms and values, the religion, healthcare service systems. And then only then you can see if a screening program will work. And if a screening program works, you have to have a management system. You have to have a good screening test. You have to control the assessment. You have to know what are the treatment, because if there's no good treatment, the screening doesn't work. You need to have evaluation. You have to know what are acceptable and desirable levels. You have to know the cost, because that's very important. But you have to also have a good screening program and a software program to manage the whole quality system. Currently, we're working on the 5th edition of the guidelines. The 5th edition of the guidelines will be much more evidence-based. The previous editions were more expert-based opinions, but now we're going really to evidence-based guidelines. And the European Commission is now charged to develop them, and they are expected in 2016. There will be new chapters also on breast centers, on reference centers, how to optimize the screening. One very important issue that will be also in the new edition of the guidelines is the quality of the radiology. In the 3rd and the 4th edition of the guidelines, it was recommended to radiologists to read 5,000 mammograms a year. I just heard that in Singapore it's 1,000 mammograms a year, but this has been a lot of debate. 5,000 mammograms a year reading is a lot. It's not a problem in the Netherlands. It's not a problem in the United Kingdom. It's not a problem in Norway and in Sweden. But in many countries, 5,000 is a lot. But why would we know we read 5,000? What is the background? If you read 5,000 mammograms and the background incidence is about 7 cancers per 1,000, you would see about 35 cancers a year. That is, then you have an irregular exposure. But there have been many studies been done also on the ROC curves. What are the receiver operating characteristics for radiologists? And then you see that there is an optimum in reading that arrives between 2,000 and 3,000 mammograms a year. If we want, what do we want radiologists to be? If they do a screening, we want that their sensitivity and their specificity are about in the green area. But how do you determine the sensitivity and the specificity of a radiologist? Because if you really want to know the sensitivity, you have to count also the interval cancers. And the interval cancers, they appear 2 years after you do the reading, and that's very cumbersome to read them. And sometimes you don't even have all this information because you're missing a good cancer registry. There is another way to determine this, and I heard that also from my colleague before, you can easily determine the sensitivity and the specificity if you have a double reading system. Because if one radiologist says it is positive and the next one says it is negative, and the third reader says it is positive and it is a cancer, the second one did not see the cancer while it was visible because his colleague did see him. So you can easily check, if you do this over a long term, if you use your colleagues as a reference, you can easily detect the sensitivity and the specificity. I've done that but then you have to say also what is an acceptable level of sensitivity and specificity. And I've been doing it for the last 10 years. And this is, for instance, an example of a radiologist that has been screening over 10 years. He does do first reading and second readings,